Thank you, Alicia. All right, let's get started for the next session. We have Dr. Richard Miller, Professor of Surgery from Vanderbilt.
Hello, morning people. Thank you. There's nothing like the morning. Great coffee and those yummy blueberry muffins, exercise and beautiful sunrise. But I'm going to be talking about a very difficult subject that we all have to deal with in the ICU, and that's death, dying, and futile care, and talk a little bit about what we've learned over the last decade or so on how to manage this. Let's start with a couple of cases. This is a 69-year-old farmer who was involved in a tractor rollover accident. He suffered a small subdural hematoma, a C5 fracture, multiple rib fractures, and a grade 2 spleen laceration. Had a history of atrial fibrillation, was just on aspirin and hypertension. He actually was on an ATV in his huge farm a year ago and did well and recovered. We put an epidural catheter in him to get pain management, but several days into his care, he started getting some agitation and delirium, which seemed to improve over several days. He was walking in the hall after day 6 or so, but then developed AFib, a rapid ventricular rate, and supraventricular tachycardia that we try to manage with beta blockers. He once again became agitated. He had altered mental status, respiratory distress, and was intubated. And we got a CT scan which showed significant cerebellar infarct and scattered embolic infarcts throughout his brain. Case 2 is a case that is still in our hospital right now. This is a 16-year-old star high school football player that was hit helmet to helmet, went to the sideline complaining of a headache and neck pain and collapsed on the side. EMS was right there. He had decorticate posturing and blown pupils. And apparently, according to his family, he had a similar episode 5 weeks prior with a concussion, but was clear to go back to sporting activities. This was his initial CT scan, which showed a very large left subdural with a shift and a lot of edema. And then, as you can see, on his birthday, when he turned 17, he had a rebleed after his craniectomy with diffuse cerebral edema, which the neurosurgeon said was malignant cerebral edema. And his MRI shows that pretty much most of his brain is infarcted. But he grimaces, he has a cough and a gag and spontaneous respirations, but that's it. So the word futility comes from the Latin word futilis, which is failing of the desired end through an intrinsic defect. It also means easily melts or pours or is leaky. And I do like this analogy of a bucket full of bullet holes where despite all of your therapy, that's futility. Now, there's a lot of types of futility. They've tried to break down all of these different futility entities: physiologic, imminent demise, lethal condition, and qualitative futility. The one that we use most frequently is physiologic futility, where the treatment won't have the intended physiologic effect. There's also been recently a document presented by the American Trauma Society that differentiates futility from potentially inappropriate treatment that have at least some chance of accomplishing the effect sought by the patient or the family, but the clinicians believe that competing ethical considerations justify not doing that treatment. There's a lot of debate in this country about futility and what counts as no realistic chance for benefit. Who really has the authority to make that final call on futility? And should futility judgments be based on us and physicians' own personal beliefs? And there have been many, many methods to try and resolve this futility dispute. In Canada, they have socialized medicine. And as a nation, they have decided to rationalize care because it's not sustainable to allow everybody to stay alive. Half the healthcare dollar in the United States is spent in the last month of people's lives. Half the healthcare dollar. So in Canada, if you have metastatic disease, if you have renal failure and COPD, you do not go on a ventilator, you do not go in the ICU. That country has made a decision based on statistics and based on the country agreeing that this is not justified. So they've rationed care. We have not come to that in the United States yet. There are some states that have legislative, multi-step due process protocols, but it's extremely painful for everybody. When you are interacting with a patient's family as a clinician, and you tell them, well, I'm sorry, but we've entered futile care. As soon as you do that, as soon as you use the word futile care, that family thinks that you've given up. And a barrier comes up between you and the family, and all that trust and thought and interactions that you had goes away. My suggestion is that we consider abandoning this concept of futility altogether. It's really an unhelpful term. It limits the family members from being part of the discussions, part of the decision making. It's much, much better to educate the families on what is realistic. What are the expectations of the patient? What would the patient want to do? What would your loved one want to do in this circumstance? Not what you would do or what you would do, what would they want to do? And offer your best medical advice and don't hide behind the word futility. Communication is the key. Chewbacca and Han Solo did not speak the same language, but they killed a lot of enemies and they were an unbelievably great team. Even though they didn't speak the same language, they understood each other. And our goal with our consultants, with our team, and with our families is to have good communication, even if we don't speak the same language. We are very fortunate at Vanderbilt to have an incredibly robust palliative care service. And I understand that a lot of hospitals don't have this luxury, but I just want to introduce it to you because I think it is an incredibly valuable tool in your armamentarium in communication with your patients and families. We are very busy. We're in the trauma bays, we're in the operating rooms, we're resuscitating, we're taking care of patients in the ICU. It takes time and effort to properly talk to patients and educate them on what the realistic end results are for their loved ones. And the palliative care service is an incredible asset to us in that scenario. We have 8 board-certified palliative care physicians, 2 case managers, a social worker, a nurse practitioner. They see 200 consults a month, 2,400 patients. The average census on their own service is about 25 to 30. And they have their own palliative care unit with an ICU and vent care and social workers and hospice care. About 25% of their consults are from our services, the ones that I am the chief for, the trauma, burn, and surgical critical care units. 25%. So we need to have a very tight relationship, and it works incredibly well. And they're not the Grim Reapers. They don't come in and say, well, we're going to figure out what to do as your loved one is in the dying process. Only 50% of the patients that they're consulted on actually do die in the hospital. They help us with transitions of care to other areas and not necessarily the grave. They have improved the communications about goals of care related to prognosis and what the patient would want. They're incredibly helpful in interact with us on what's a good time that we can have a family conference together in an appropriate area of the hospital. They provide a fresh presentation to the case, and they often don't have the same emotional investment in the patient that we do. They help us with end-of-life issues, grief counseling, transitions of planning, and spiritual support. And they should be introduced proactively, not as a reaction to a debate between you and the family. And they help promote the open dialogue between the team and the family. And we all work together in achieving the best outcome for the patient versus some divisive or adversarial debate that you may have when you use the word futility. And they, most importantly, encourage collaboration on what we call a shared decision-making. And what we've done at Vanderbilt is we have multidisciplinary rounds every day with 2 family members rounding with us. So they're actively involved every single day in the decision-making for the patient. So they see what's going on and they get a better idea and they start to understand our language. And we can communicate better. But this shared decision-making is very complicated. And there's a lot of people involved. And it's a huge network when you really think about it. We have the multidisciplinary ICU critical care team, and then we have this huge family network that is involved in this decision-making on somebody that is critically ill. And then when you join those together, those 2 forces together, it can be very challenging in how to interact, who the appropriate surrogates are, and then deciding on transitions of care. So it's a challenging entity to go through. Ann Mosenthal suggests that you integrate palliative care frequently in surgical and trauma ICUs in the appropriate setting. And they suggest that you incorporate palliative care service into your daily work rounds and you assess which patients might benefit from it. 20% of the population dies in the ICU. About a third die if you've spent over 7 days in the surgical ICU. And that doesn't include the people that went to an LTAC or a SNF or were dependent on others for the rest of their life. So within 24 hours, folks up in the Northeast, they assess the patient, the family, the prognosis of the patient, the treatment preferences, and then within 72 hours, they have a multidisciplinary team meeting with the family, addressing the prognosis and the goals of care, and it's really improved the delivery, the understanding, and the communication in this specific patient population. And Karen Brazel and Kathy Bradley suggest that there are specific guidelines that you should follow. And interestingly, when they looked at the reasons for involving palliative care, the first reason was the family requested it because they were having debates with the primary care team. Or the primary care team said that futility had been entered within this patient. A lot of times the family disagreed with the medical team on the direction. Other reasons for palliative care were that death was expected in the same ICU stay, or somebody that spends over a month in the ICU carries a very bad prognosis. Folks over 60 that have multi-organ failure, brain death is confirmed or imminent, carcinomatosis, transtentorial gunshot wound, and one of the largest ones was a Glasgow Coma Scale less than 8 in a geriatric trauma patient that was badly injured. And this comes from the practice management guidelines in East that shows that elderly patients over 65 that have a severe traumatic brain injury with initial GCS less than 8 and remains low after 3 days, 80% of those people die and the remaining are dependent on others for the rest of their life. So a GCS less than 8, which remains low after 3 days in someone over 65, really warrants a strong consideration on goals of care and end-of-life issues. And this is the interest of my most recent research, is to determine which of the elderly patients are at highest risk of dying either in the hospital or within a year after their injury. And Kathy Maxwell is a PhD nurse that is headed the study that we just presented at the AAST and will be in the Journal of Trauma on the cognitive decline and physical frailty really predicts both 6-month and a year outcome in these elderly patients. Physical frailty is defined as a medical syndrome with multiple causes that's characterized by diminished strength, endurance, and reduced physiologic function. And it is a clinical marker of physiologic age. When we're injured, we have a certain amount of physiologic reserve, and the higher the injury severity score, the faster you deplete your physiologic reserve until you are physiologically exhausted, and then you die. You've depleted all of your compensatory mechanisms to keep you alive. The young and healthy have an incredibly high physiologic reserve and can tolerate a huge hit. But unfortunately, as we age and as we develop underlying disease, our physiologic reserve diminishes, and we reach physiologic exhaustion a lot quicker. It's physiologic age. Now, these are two triathletes that I know. Jacques over there on the left is 73 years old. But physiologically, he's probably about 60, maybe even 50. And Joan over there has won her age group 5 years in a row. And these people are not physiologically 65, but Herb and Mabel here are probably physiologically older than they are. They have a lot of comorbidities, they're frail, and their ability to tolerate a big hit is extremely low. And here, you heard this in the last few days, this is going to be an epidemic in the United States in the next 10 years. Look how many, 70% is the mechanism of injury on elderly patients after they fall. What's wrong with this picture? It's pretty obvious. Anybody? Well, she's old, right? She's gray, she's old. She has nasal alloflaring. She's got an incision over her left chest. What's that? She's got a pacemaker. She's AFib. She's on Eliquis. She's on aspirin. She's on Plavix. She fell. She whacked her chest. She broke her hip. And soon after, she went into respiratory distress, was intubated, and she was dependent on others, had multiple comorbidities, and we come in and we leave this world dependent on others, and she was actually at a daycare for elderly people and had fallen at that daycare, and she died 7 days later from her injury. It's a bad sign. So what we've done in this study, what we published in the Journal of Trauma coming up, is that we interviewed either the patient or the surrogate within 2 days of their admission, and then did a brief screening on their frailty, their disability, their mobility for physical frailty, and their memory and thinking for cognition. And here, look at it, look at this. 67% of our patients that were admitted to the trauma service were a result of some sort of fall in that year, 67%. About a third, we found out, had some sort of cognitive impairment consistent with dementia. And well over half had some significant frailty. And I thought this was interesting, and it's a lesson to all of us to stay in shape. At least once a week, do you engage in regular activities like brisk walking, jogging, bicycling, swimming, long enough to work up a sweat and get your heart thumping or get you out of breath? And only 30% of these folks over 65 said yes. And it makes a huge difference on their outcome. I promise you. Get your parents to start working out. Pre-frailty is the one that we're focusing on. It's an intermediate stage in the frailty trajectory that you actually might be able to make a difference on. And one of our sub-aims was to look at this group and see if we can make a difference, because everybody that's frail and falls or injured doesn't do well. Every single one of the people that had frailty before they were injured either died or were dependent on others for the rest of their life. But that's the red ones. The yellow ones were pre-frail, where they become close to frail during their injury, but we can actually improve their outcome and get them better for the ones that survived. And the green ones recovered quickly. So if they weren't frail and they were injured, they actually recovered. So the conclusion from our study was that very few survivors after injury returned to their baseline functional status at 1 year. But if they weren't frail, we could get them there. Pre-injury disability is the primary predictor of functional status at 6 months and a year. Age, injury severity, and pre-injury disability predicted mortality at 1 year, and the most important thing was physical frailty. As a measure of disability was the predominant predictor of the people that died. So if someone's frail and injured, they will not do well. 25% of our patients died within 1 year, and most of them were frail. So our next step is we're submitting an R21 investigational grant. This is going to be a multi-institutional study utilizing what I'll show you in a second, called the Simple FRAIL questionnaire as a screening tool to get an early palliative care consult and quantify our outcomes in a proactive way with geriatric patients. And this is it. It's easy, and everyone can remember it. And we're going to have this questionnaire at the bedside, the Simple FRAIL screening. If you have 3 or more of these 5 things, you're frail. If you have 1 or 2, you're pre-frail. If you have none, you're not frail. And it will predict your outcome, we believe, in our hypothesis. FRAIL stands for F is fatigue. Does the patient fatigue easily? R is resistance. Can the patient walk up 1 flight of stairs? A, ambulation. Can they walk 1 block or 1/4 of a mile? Illnesses. Does the patient have more than 5 different comorbidities? And finally, loss of weight. Has the patient lost more than 5% of their weight in the last 6 months? And we believe that if we use this questionnaire and they're frail or even pre-frail, and we get palliative care involved early, we're proactive about the pre-frail, and we talk to them about end-of-life issues on the frail ones that are badly injured because they're not going to do well, we're going to make a big difference. Because remember, half the healthcare dollar is spent in the last month of life, and most of those patients are elderly. So, case 1, which way did they go in the fork in the road? Well, with good palliative care, a good understanding that this farmer would not go on his tractor again, would not do the things that he loved to do. We discussed that. They clearly understood that he would not want long-term care, and we went through comfort measures. He went to the palliative care unit. He was surrounded by his family, and he died peacefully. But it's a lot harder decision on a 16-year-old high school kid with 3 siblings with a whole life ahead of them, and they see that grimacing and they see that coughing and breathing, and they just can't accept the fact. The answer, because I can't predict everything, they've made the decision. We've done a trach and a peg, and he's going to go to a long-term health care facility. And we don't know what the outcome is. Maybe he'll improve. Most likely he won't. So just a few take-home messages. Maybe not use the word futility when you're interacting with patients and families. It's probably not the right nomenclature. It's much better to have communication and education and interaction and spend time with them. Use the resources you have to spend the time and communicate and educate the family and find out what the patient would want to do in that circumstance. But if you're pouring in all you can, all your resources to take care of a patient, and the end result is the bucket is empty, then probably the best way to go is to make the patient comfortable and educate the family on end-of-life issues. It's a tough area, but I think we can make a big difference. Thanks for your attention.
Thank you, Dr. Miller.